So appendix is a very important topic for the exam, both from your college exam point of view and from the entrance exam point of view. Invariably in the college exams, you get a short note on appendicitis or on Oshner-Sharon regime, and lots of MCQs are also asked from this module. So before we talk about the actual conditions in appendix, let's talk about the anatomy, which is also very important, and given that the next exam is coming up, there are a lot of surgical anatomy correlates which you need to know from appendix. So the first thing which you need to know are the positions of the appendix. Now there are various positions which are there, but the questions which have been asked in the exam is that retrocecal. So retrocecal is the most common. Retrocecal is the most common location of the appendix. Whereas post-ileal, so post-ileal is the least common. Post-ileal is the least common location of the appendix. Okay. And following retrocecal, the second most common is pelvic appendix. Second most common is pelvic appendix, which is 21%. Now we know that the location of the appendix is constant. The location of the base of the appendix is constant, and it is situated at the junction of three tinea coli. You know, tinea coli are the longitudinal bands of muscle which run along the large bowel, and at the junction of the three tinea coli, that is where the base of the appendix is located, and that is a constant position. The other points in the surgical anatomy which you need to know for the exam, that appendicular artery is a branch of the lower division of the ileocolic artery. This question has been asked many times in the exam. It is a branch of the lower division of the ileocolic artery, and the accessory appendicular artery is also known as the artery of Sesacellum, and this is a branch of the posterior cecal artery, right? So this is a branch of the posterior cecal artery. Don't get confused. Appendicular artery is a branch of the lower division of the ileocolic artery. Now, appendicular artery is an end artery. It is an end artery, and majority of course is in the mesoappendix. Majority of its course, it lies in the mesoappendix. Okay, but the terminal portion of the appendicular artery, that means in the region of the tip, is not in the mesoappendix. And because it is not in the mesoappendix in the terminal portion, this can get thrombosed. This can get thrombosed when there is inflammation. This can get thrombosed, and if this gets thrombosed, it can predispose to a perforation. And that is why when I talk about appendicular perforation, I will tell you that appendicular perforation is most common where? Correct, at the tip of the appendix, because this vessel gets thrombosed and that tip area can easily break open. So that is the most common site for perforation in appendix as well. So these are the points in the surgical anatomy which I wanted you to know. Let's move on to the most important topic in this module, that is acute appendicitis. Now, acute appendicitis is inflammation of the appendix. Acute appendicitis is inflammation of the appendix, and this can either be due to luminal obstruction. Or it can be catarrhal, which is non-luminal obstruction, or it can be catarrhal appendicitis. So acute appendicitis can occur because of two main reasons. One is because of secondary to luminal obstruction, and the other one is catarrhal or non-obstructive appendicitis. Right? Now, almost 85 to 90% of the times it is due to luminal obstruction, whereas only 10% of the times it is catarrhal or non-obstructive appendicitis. And this catarrhal or non-obstructive appendicitis is usually seen in children. Now, in obstructive appendicitis, what usually happens is that the lumen gets blocked. Lumen gets blocked by most commonly a fecalith. So most commonly it is a fecalith which blocks the lumen of the appendix, right? And this fecalith is comprised of calcium phosphate. Most commonly. So this is the most common thing which blocks the lumen of the appendix. The other causes can be ascariasis, food particles, or tumors like carcinoid tumors. They can also block the lumen of the appendix and they can predispose to appendicitis, but the most common being fecalith. Now what happens is that once the lumen gets blocked, when the lumen is blocked, the pressure increases. There's increase in pressure. And when the pressure increases inside the lumen, it first causes venous compromise. And then the pressure increases further and then it causes arterial compromise. So this is how appendicitis develops post-luminal obstruction, and you should know about this. Now, what are the clinical features of acute appendicitis and how do we diagnose acute appendicitis? That is very important to know for the exam. So if we talk about the incidence of appendicitis, then it is uncommon in infants and elderly patients. It is common in children. And in children, there is equal male to female incidence which is seen. The maximum incidence of acute appendicitis is seen in the teenage years, where males are more commonly affected than females. So I was also in class 8th when I developed acute appendicitis and I had to undergo an appendicectomy. And it was just sheer coincidence that while I was getting operated, my first cousin in America, she had an appendicular perforation. So mine wasn't perforated, but she had an appendicular perforation, and almost at the same time, both of us underwent appendicectomy. So the maximum incidence is in the teenage years. Now, to diagnose acute appendicitis, of course, the patient is going to present with certain symptoms. We have to carry out certain signs, and there are certain lab investigations which are carried out to make the diagnosis. Now, the symptoms, of course, the most common symptom of acute appendicitis is pain. And the patient will typically complain of shifting pain. Shifting pain is that it starts in the periumbilical region. And shifts to the right iliac fossa. Patient can also have nausea and vomiting. Anorexia is a very important symptom which is there. And fever is usually a late symptom which is there. Which is seen with acute appendicitis. So these are the symptoms with which the patient can usually present to the emergency. Now, there are certain signs as well which can be carried out in patients of acute appendicitis, and I will talk about the signs in detail, but before I do that, I want you to know about the Mantrel scoring system. This is the Mantrel scoring system or the modified Alvarado score. So this is the Mantrel's or the modified Alvarado score, and this helps us in making a diagnosis of acute appendicitis. Now, this is not the only scoring system which is used in appendicitis. So you also have the adult appendicitis score. You also have the pediatric appendicitis score. And you have the Xenakis scoring as well. The Xenakis scoring is done as well. So these are the other scores which are used, but the most common is the Mantrel's or the modified Alvarado score. Now, what exactly are we seeing in the Mantrel's or the modified Alvarado score? So the name Mantrel's came because the mnemonic is Mantrel's, the first alphabet of each of the problems. If you see the first alphabet, that is going to make it Mantrel's, right? Now, M stands for migration of pain to the right lower quadrant. This is given a score of 1. Anorexia is given a score of 1. And nausea and vomiting, this is also given a score of 1. These I told you are the symptoms. These I told you are the symptoms which are there with which the patient can present. Then tenderness in the right lower quadrant, rebound pain, elevated temperature. These are the signs. And out of these, tenderness in the right lower quadrant is given a score of 2. Rebound pain and elevated temperature are given a score of 1. And these are the signs which we see. These are some of the signs which we see which are included in this scoring. And finally, you have leukocytosis and shift to the left, right? That means increased neutrophilia is going to be there. Again, leukocytosis is given a score of 2. And these are the lab investigations which are done in patients with acute appendicitis. So if you add this up, the total score is out of 10. The total score is out of 10, out of which only 2 findings, that is tenderness in the right lower quadrant and leukocytosis, are given a score of 2 each. Otherwise, each one is given a score of 1. This scoring system you need to remember for your exam because questions have been asked from it. Now, if we see the scoring, a score of less than 4 to 5, appendicitis is unlikely. Appendicitis is unlikely. So this score has a high negative predictive value. It has a high negative predictive value. That means if the score is less, it helps in ruling out appendicitis with more sensitivity and specificity. Okay. If the score is less, it helps in ruling out appendicitis with higher sensitivity and specificity. Okay. If the score is 5 to 6, appendicitis is possible. 7 to 8, appendicitis is likely. And 9 or 10, appendicitis is highly likely. But like I said, that a lower score is more likely to rule out appendicitis than a higher score confirming the diagnosis of appendicitis. Okay. So this you should know about the Mantrel scoring system. Now the other signs which are there, we were talking about the signs of acute appendicitis. And the signs of acute appendicitis are: number 1, there is tenderness at the McBurney's point. So there is tenderness at McBurney's point. There are a couple of points which you need to know here. First, you need to know what is the surface marking of the McBurney's point. This has been asked in the exam. So this is the spino-umbilical line. What is drawn here is the spino-umbilical line. Spino-umbilical line means it joins the anterior superior iliac spine with the umbilicus. The anterior superior iliac spine with the umbilicus. Right. Now, at the junction of the lateral 1/3, this is lateral and this is medial. So at the junction of lateral 1/3 and medial 2/3, at the junction of lateral 1/3 and medial 2/3, that is where the McBurney's point lies. And there is tenderness at the McBurney's point. Now, why is there tenderness here? This occurs when the parietal peritoneum becomes involved. When the parietal peritoneum is inflamed, that is when pain is going to shift to the right iliac fossa. Otherwise, prior to this, there is dull periumbilical pain, which is because of the visceral stretching or the visceral peritoneal involvement. But parietal peritoneum, there is more localized pain. You can localize pain better when the parietal peritoneum is inflamed. So the pain is going to shift to the right iliac fossa. The other named signs which you should know about, you can have the pointing sign. Pointing sign is when the patient points towards site of maximum tenderness. Patient points towards the site of maximum tenderness, and this is usually in the right iliac fossa. The other signs are Rovsing sign. Rovsing sign has been asked in the exam. Rovsing sign is when you press the left iliac fossa. When we press in the left iliac fossa and there is pain in the right iliac fossa. There is pain in the right iliac fossa. And why this occurs, there are two mechanisms which have been hypothesized for Rovsing sign. One is when you press in the left iliac fossa. When I press in the left iliac fossa, the bowel loops get shifted to the right. They get shifted to the right and they can cause pain. Or the other one is when I press here, gaseous distension occurs in the cecum. Right? When I press in the left iliac fossa, gaseous distension retrogradely occurs in the cecum and that can increase the pain. So that is Rovsing sign. Another sign which has been asked is the psoas sign. Is the psoas sign, also known as the Cope-Psoas test. Psoas sign or the Cope-Psoas test. So this psoas sign or the Cope-Psoas test can be done by two methods. One is by hyperextension. One is by hyperextension of right hip. This is the classical description of the Cope-Psoas sign in various books. Hyperextension of the right hip. You make the patient lie down and hyperextend the right hip, and that will cause pain in the right iliac fossa. There will be pain in the right iliac fossa. Pain in right iliac fossa. Okay. Or the other one is flexion against resistance. Other one is flexion against resistance. So these can elicit pain in the right iliac fossa, and this is the psoas sign or the Cope-Psoas test. I have shown a small clipping where I've demonstrated the surface marking of McBurney's point, and also I've demonstrated Rovsing sign, psoas sign, and the obturator sign. So that video will follow once I've described these signs. The other test or the other sign is the obturator sign, and the obturator sign is flexion and internal rotation of the hip. Flexion and internal rotation of the hip gives rise to pain in the right iliac fossa. That is obturator sign. Now, there are certain non-specific signs as well which can be elicited in acute appendicitis. And what are these non-specific signs? These non-specific signs are Dunphy's sign. Dunphy's sign is pain on cuffing. You have the Aron sign. The Aron sign is when you press in right iliac fossa, when you press in epigastrium. When you press in the epigastrium, there is pain in the right iliac fossa. But again, this is a very non-specific sign because even in other conditions you can have this. And finally, you have the 10-horn sign. The 10-horn sign is when you pull the right testis. When you pull the right testis, there will be pain in the right iliac fossa. So these are some of the signs which can be seen in acute appendicitis, which you need to know for the exam. Now, you can see in the clip on examination where I've depicted these signs. So you can see here I've marked the spino-umbilical line. This is the umbilicus. This is the anterior superior iliac spine where I'm pointing. And this spino-umbilical line, along the spino-umbilical line, lateral 1/3 and medial 2/3 is where the McBurney's point is situated. So this is the McBurney's point, and this is the site of maximum tenderness during acute appendicitis, right? One more sign is the pointing sign, where if you ask the patient to point at the site of maximum tenderness, the patient will point at the McBurney's point. So you can see here, that is the site of maximum tenderness. Everyone should know the surface marking of the McBurney's point. It is asked in your table vivas, in your exam as well. Now, if we talk about some of the named clinical signs in acute appendicitis, you can have Rovsing sign. So Rovsing sign is when I press in the left iliac fossa. So when I press in the left iliac fossa, there will be pain in the right iliac fossa. And the reason why Rovsing sign occurs is because the bowel gets displaced and the gas gets displaced, and that gives rise to pain at the right iliac fossa or at the McBurney's point. That is the Rovsing sign. There can be another non-specific sign known as the Aron sign. The Aron sign is if we press in the epigastrium, then there's going to be pain in the right iliac fossa. That is Aaron's sign. There are two more named signs which I want you to know. So two more named signs. So you have the psoas sign and you have the obturator sign. So psoas sign, there are two ways to elicit psoas sign. One, you can do flexion of the right hip against resistance. So you can see here that I'm going to do flexion against resistance. And when there's flexion against resistance, there's going to be pain in the right iliac fossa. That is one way of eliciting psoas sign. The other way of eliciting psoas sign is to carry out hyperextension of the hip. So there you can see flexion against resistance is going to give rise to pain in the right iliac fossa. That is the first way of eliciting psoas sign. The other way of eliciting psoas sign is to do hyperextension of the right hip, and that will give rise to pain in the right iliac fossa. So you ask the patient, the right side should be up, right side up, and now we are going to do hyperextension of the hip. You can see I'm doing hyperextension of the hip, and when I do hyperextension, the patient will complain of pain in the right iliac fossa. The final named sign which you should know about is known as the obturator sign, and the obturator sign is when we do flexion and internal rotation of the hip, and that will give rise to pain. So this you can see is the psoas sign where hyperextension is being done, and this is another way of eliciting pain in the right iliac fossa. This is the psoas sign, and this would usually occur in a retrocecal appendix which is pressing on the psoas. That is going to irritate, and that can give rise to pain. Finally, we have the obturator sign. The obturator sign is when we are going to flex the hip, that there's flexion being done and the hip is going to be internally rotated. So flexion and internal rotation of the hip will give rise to pain. That is the obturator sign. There you can see flexion and internal rotation. Patient will start complaining of pain in the right iliac fossa. So these are the various clinical signs in appendicitis which you should know about. Now, depending on the location of the appendix, depending on the tip of the location of the appendix, there can be peculiar presenting features. So in Bailey, they've given 2 or 3 different locations, and what are the specific or what are the peculiar features there which I want you to know for the exam. So we know that retrocecal appendix is the most common, and retrocecal appendix psoas sign will be present. I've already demonstrated psoas sign for you. And because of pain, the patient will usually keep the right leg in flexion when there's a retrocecal appendix. When there is a pelvic appendix, when the appendix is in the pelvic region, then this pelvic appendix, the tip can irritate the bladder, irritate the rectum, and if it irritates the bladder, the patient is going to have increased frequency of micturition, and it can be misinterpreted as a urinary tract infection. Okay. When it irritates the rectum, we have discussed in the module on postoperative fever that if there's a collection in the rectum, a collection in the pelvis, or if there's constant irritation of the rectum, the patient can have pelvic diarrhea. The patient can have diarrhea and tenesmus, and there can be pain on digital rectal examination in a pelvic appendicitis. And post-ileal appendicitis. Post-ileal is the least common site, and it is the most difficult to diagnose. It is the most difficult to diagnose. And because it is the most difficult to diagnose, that is why this appendix can rupture and cause perforation with hardly any signs, right? So there are hardly any signs, and there's just slight pain on deep pressure when there is a post-ileal appendix. So these were the typical presentations based on the location of the appendix. Now, acute appendicitis is a very common problem, but in each specific age group, there can be other differential diagnoses as well. And in Bailey, different tables have been mentioned for these differential diagnoses. I want you to know some of them because with the next exam coming up and more clinical scenarios coming up, you should be able to differentiate appendicitis from other conditions. So if we talk about infants and children, in infants and children, a very common diagnosis, and this clinical scenario also you can get, is Yersinia, which can give rise to mesenteric adenitis. And how do we differentiate? The patient will complain of right iliac fossa pain as well, although in mesenteric adenitis it will be intermittent pain, and in mesenteric adenitis, fever will be more common than acute appendicitis. So that is how we differentiate acute appendicitis from a Yersinia infection. Again, intussusception, which we've already discussed in the module on bowel obstruction. In intussusception, there can be pain in the right iliac fossa or the right lumbar region, which can also be misinterpreted as acute appendicitis. Ureteric colic, Meckel's diverticulitis, very, very important. If you remember, I've told you when I spoke about Meckel's diverticulum, that Meckel's diverticulum can mimic features of acute appendicitis, right? And if you find a normal looking appendix when you're doing appendicectomy, you should always search for an inflamed Meckel's diverticulum. Very important point. Bowel obstruction is another differential diagnosis. In adults, again, it can be ureteric colic, it can be bowel obstruction, it can be torsion of the ovary, it can be torsion of the testis, which can give rise to pain in the right iliac fossa, or gastroenteritis also, which can be a differential diagnosis. In females specifically, very important, Michel's-Merz. Michel's-Merz is mid-cycle ovulatory pain, and on the right side, this can mimic acute appendicitis. So we should always take a menstrual history in a female who's coming with right iliac fossa pain. Endometriosis, again, menstrual history will help with that, and it'll be monthly or cyclical pain, so that history would also help you. Pelvic inflammatory disease and ectopic pregnancy also can be differential diagnosis. In elderly patients, you can have diverticulitis, ureteric colic, and obstruction as differential diagnosis for acute appendicitis. Now, we've already discussed the symptoms, we've discussed the signs, we've discussed the lab investigations. So in the lab investigations, there'll be increased total leukocyte count and there'll be increased neutrophils. Also, there can be increased C-reactive protein, but increased C-reactive protein is not specific. It does not signify that the patient has appendicitis. It will be raised in any inflammatory condition. Now, to confirm the diagnosis, we have to do certain imaging tests. And the investigation of choice in adults is a contrast enhanced CT scan, whereas in children it is an ultrasound. Whereas in adults it is CECT, in children it is an ultrasound, which is the investigation of choice in these patients. We'll discuss that in pregnant patients, MRI also has a role, but for adults and children, you should know the investigation of choice. Now, what exactly do we see on the ultrasound? So, an ultrasound, what are the findings which are suggestive of acute appendicitis? The findings are going to be a blind ending tubular structure. So, there'll be a blind ending tubular structure. There will be probe tenderness. When the radiologist presses on that area, there will be probe tenderness. The patient will complain of pain. The diameter is more than 6 to 7 millimeter diameter is there. There is periappendiceal fluid collection. Periappendiceal fluid collection. So all these signs are suggestive of acute appendicitis. So non-compressible blind ending tubular structure, diameter more than 6 to 7, there's probe tenderness and periappendiceal fluid collection. All these findings are suggestive of acute appendicitis. Now, once we've confirmed the diagnosis of acute appendicitis, we have to take up the patient for surgery. So the management of these patients, once the diagnosis has been confirmed by clinical examination, by radiological and lab tests, then we have to take up the patient for appendicectomy. Right. Non-operative management has very high recurrence rate. Non-operative management has very high recurrence rate, and this has been seen in multiple trials that it has a very high recurrence rate, and it should only be done if there is contraindication for surgery. right? If the patient is not fit enough for surgery, if there's a contraindication for surgery, then only the patient should be put on non-operative management. And non-operative management would basically mean bowel rest. That means make the patient NPO. And these patients are given IV antibiotics and IV painkillers, right? So non-operative management is hardly done. If we have a confirmed diagnosis, we will take up the patient for appendicectomy. Now, when we take up the patient for appendicectomy, this can either be lap appendicectomy, which is gaining a lot of popularity, and in a lot of centers this has become the standard of care, or it can be open appendicectomy, In your exams, majority of the questions are being asked from open appendicectomy. So if we talk about open appendicectomy, what are the various incisions which can be used when we are carrying out an appendicectomy? This you should know for the exam. So you can have a McBurney's incision. And McBurney's incision is of two types. So one can be a grid iron incision. A grid iron incision is a muscle splitting incision. Where we don't cut the muscle is only split. It's a muscle splitting incision. And why do we call it grid iron? Grid iron it is known as because in anatomy Dr. Raviraj has taught you that the internal oblique and the transversus, they run at right angles to each other. So the internal oblique and the transversus, the fibers run at right angles to each other. So if I split these muscles, you can see, if I split them, you're going to get a square or a grid. You will get a square or a grid. If you look from a distance, you will see a square or a grid, and that is why this incision is known as a grid iron incision. Okay. Now, sometimes when you're doing a grid iron incision, there is less space available, right? The area is restricted. So, if you cut the muscle, then it becomes a Rutherford-Morris incision. And Rutherford-Morris incision is a muscle cutting incision. Which gives you more access or more space to carry out the surgery. Now, in the recent INI-CET exam, they had asked what are the layers which are cut in the Rutherford-Morris incision. And I've been telling you for most of the surgeries, I've been talking about the various layers we go through. Because with the next exam coming in, these are the applied anatomy questions which can be asked in the surgery paper. So the various structures which we are going to go through are skin, subcutaneous tissue. You have the two layers of the superficial fascia, your scarpas and campus fascia, two layers of superficial fascia. You have the external oblique aponeurosis. Then you have the internal oblique. Then you have the transversus. Then you will have preperitoneal fat. And finally, we incise the peritoneum. So these are the various structures which are incised when we are doing a Rutherford-Morris incision. Now, please, in this image, don't get confused. This Rutherford-Morris incision will be on the right side. Just because I didn't want to crowd up the area on the right side, that's why it's been shown on the left. But of course, appendix is on the right. So that is why it will be on the right side. So Rutherford-Morris incision will also be on the right side. And these are the various structures which we cut. Now, the other incisions which can be used, you can see the Lanz incision. The Lanz incision is also known as the skin crease incision. It is also known as the skin crease, also known as the bikini incision. Right? So this is the incision which I got when I had my appendicectomy. And the advantage of this incision is that it is hidden in the skin crease. So you can't see the scar. Once the scar heals up, you can't see the scar. That is why if somebody, like if I go for swimming, if I'm wearing my swimming trunks, you cannot make out the scar because it is very well hidden in the skin crease. So that is the beauty of the Lanz incision. And Lanz incision is mostly used when interval appendicectomy is being done. Interval appendicectomy means when we are doing it not in the acute setting, but after a gap of 4 to 6 weeks. The final incision which can be used is a lower midline incision. This is a lower midline incision, and in various modules I've already told you what are the structures which are cut in the midline incision. Now this lower midline incision is usually used when there is a perforated appendix. When there is a perforated appendix, that is when we are using this incision. So these are the various open incisions which are used during appendicectomy. Now appendicectomy can also be done laparoscopically, and lap appendicectomy, you can see that there are 3 ports. There's usually a 3-port technique which we use while we are doing laparoscopic appendicectomy. So the first port is the infraumbilical port through which your camera is going to go, your infraumbilical port. You can have another port in the left iliac fossa, and you have a third port in the suprapubic region. You have a third port in the suprapubic region. And you can see that the surgeon is usually standing on the left along with the assistant. They're standing on the left side so that they can easily approach the appendix on the right side. So this is lap appendicectomy. And I will just tell you the steps of appendicectomy, and then I'm going to show you an operative video where these steps have been demonstrated during actual surgery. This is very important to know because even in final year, one of the CHIT vivas is where you have to tell the steps of appendicectomy. So you should be well versed with these steps. So in appendicectomy, of course, we first have to cut the skin, we cut the subcutaneous tissue, we are going to cut the superficial fascia, then the muscle layers we either split or we cut them. We open up the peritoneum after that. Now, the various things which I want you to know. Number 1, once the peritoneum has been opened, first we have to locate the appendix. And in the starting of the module, I told you that the appendix, the base is situated at the junction of 3 tinea coli. The base is situated at the junction of the 3 tinea coli. That's a constant location for the base of the appendix. So that is how you locate the appendix. Right? Once we've located the appendix, what are the various steps which are done to carry out an appendicectomy? So once we've located the appendix, then the next step, you will have the mesoappendix. This is the mesoappendix in which the appendicular artery runs. And the mesoappendix is attached to the appendix. So what we have to do is that we have to tie the appendicular artery and bare the appendix. That means remove the mesoappendix of the appendix. So second is you ligate the artery and bare the appendix. That means remove the mesoappendix from the appendix. Once we've done this, once the appendix is bare, then we are going to put a crushing clamp on the base. We put a crushing clamp on the base, right? This is the base. We put a crushing clamp on the base, right? After that, we remove this clamp and we go more distally. This is the base. We first put a crushing clamp, then we remove it from here and we go more distally. I put it more distally now, okay? So, crush the base and move the clamp more distally. Then we transfix the base. What do you mean by transfix the base? By transfixing of the base means we are going to pass a suture through the base. We are going to tie it on both the sides so that the lumen of the appendix is closed, right? We transfix the base. Once we've transfixed the base, then we are going to cut the appendix. Then we are going to remove the appendix. Okay. Then now these are the various steps which are involved during appendicectomy. There are certain special scenarios which I will be talking about in just a few minutes after you've seen the operative video. But these are the basic steps. Now one thing which you should know, that the stump of the appendix, this stump which is left behind, should be less than 4 to 5 millimeters. It should be less than 4 to 5 millimeters. Because if it is more, it can give rise to stump appendicitis. It can give rise to stump Appendicitis, very important for the exam. This has been mentioned in the latest Sebastian as well. Stump appendicitis is when this stump which is left behind inflames and it gives rise to features similar to appendicitis. And when we were in medical college, we, of course, after doing the appendicectomy, we never paid so much attention to the patient when they were coming back, and even if they were complaining of right iliac fossa pain. But in the corporate setup, when I spoke to my friends, I have seen a couple of cases who've come back with some appendicitis and have undergone re-operations. So if a patient is complaining of recurrent pain in the right iliac fossa post appendicectomy, this is one of the entities with which we should entertain and which we should rule out as well in the patient. So this is an operative video of appendicectomy where you can see we can either use the McBurney's incision or the Land's incision. And once we make the incision, we are going to cut through the superficial fascia and we're going to encounter the external oblique aponeurosis. So we cut the external oblique aponeurosis, that is the glistening aponeurosis which is being cut, the external oblique aponeurosis. And once that is done, we can see the muscles, right? The internal oblique and the transversus, which can be split, right? If we split them, we get the grid iron incision, or if we cut them, we get the Rutherford Morris incision. Okay. So once we've split the muscles, then we're going to encounter the peritoneum, and you can see the surgeons lifting the peritoneum here and now incising the peritoneum. So we do this very carefully so that we don't injure the bowel beneath. So this is the peritoneum which is now being incised. So we've entered into the abdominal cavity. And then we identify the appendix because it lies at the base of the 3 tinea coli. So that's the appendix which is being delivered, and you can see the appendix is inflamed, angry looking, and the mesentery of the appendix is attached with it. Now the surgeon is going to dissect the appendicular vessel in the mesentery, and they're going to ligate the vessel, the appendicular artery in the mesoappendix. So that is what is being done. The appendicular artery is being ligated. Once the appendicular artery is ligated, we are going to bare the appendix and then we crush the base and we proceed with our appendicectomy. So now the appendicular base is being crushed. As we've discussed, the appendicular base is being crushed. After that, we transfix the base. So it is transfixed by passing a vicryl suture through the base. We're going to tie the base out on both the sides. We transfix it and then we cut the appendix using a blade. That is what you will see next. So that is the appendix which is being cut. And once the appendix has been cut, we usually don't bury the base. Only if the base is also inflamed, then only we bury the base. Once that is done, we're going to close the incision. So all the layers which we had incised, we will close the peritoneum, then we'll close the aponeurosis as well, and then the skin layer is also closed. So these are the steps in appendicectomy which you should know about. I've already told you the various scenarios in appendicectomy which have already been covered in the module. So that is the aponeurosis now which is being closed, and then finally the skin incision will be closed in layers as well. So these were the steps of appendicectomy. I want you to see the operative video now, and then I'll discuss the special scenarios. Each scenario has been asked as a question in the exam. Now, what are these special scenarios which I was talking about? So, please remember that appendicectomy is one of the first surgeries a first-year postgraduate is going to do. Independently do. So, usually after doing a few appendicectomies under supervision, they are left with an intern like you and they are asked to carry out an appendicectomy. So, of course, they're very excited, but sometimes they do run into troubles as well. So, let's discuss these peculiar scenarios which they can run into. Number one, the appendix cannot be located. Appendix cannot be located. So if the appendix cannot be located, what is the troubleshooting which needs to be done? You identify the tinea coli. And trace them till the base. Trace them till the base of the appendix. Okay, so that is the troubleshooting which needs to be done. Number two. So the surgeon and the intern identify the appendix, but the appendix is not inflamed. right? There is not a single neutrophil there. It is not inflamed. And suddenly you see that the postgraduate's face has become blank, right? He was expecting that the appendix would be nice and inflamed and he'll carry out an appendectomy, but the appendix is not inflamed. Now, what do we do when the appendix is not inflamed? Very important scenario. So what do you do here? Do you remove the appendix and you ask your pathology friends to report it as acute appendicitis? Or do we do something else? Correct. This scenario has been asked. If the appendix is not inflamed, we search the last 2 feet of ileum. And why are we searching the last 2 feet of ileum? We are searching it for an inflamed Meckel's diverticulum. We are searching it for an inflamed Meckel's diverticulum, which can mimic acute appendicitis. So we should do this. We should search the last 2 feet of ileum in case the appendix is normal. Of course, if you don't find the Meckel's diverticulum there, you will carry out an appendectomy. You should carry out an appendectomy, but first explore the last 2 feet of ileum before you do that. The third situation is when the base of the appendix is inflamed. Base of appendix is inflamed. Right? So normally when I told you about the steps of acute appendicitis, I told you that we don't bury the base. I did not talk about burying the base of the appendix. But if the base of the appendix is inflamed, you should remember 2 things. Don't crush the base, otherwise the appendix would just avulse out. So don't crush the base. And number 2, we have to bury the base. We have to bury the base of the appendix. And there are 2 ways to bury the base of the appendix. I've already spoken about in detail about purse string sutures in the module on suturing techniques. Purse string sutures, I've also shown you how a purse string suture looks like. Or we carry out a Z stitch. And these are the 2 techniques which we use to bury the base of the appendix. The fourth and the final scenario which you should know is that the base is gangrenous. The base of the appendix is gangrenous along with adjacent cecal wall. So along with the adjacent cecal wall, the base of the appendix is also gangrenous. And in this situation, we have to carry out a right hemicolectomy for these patients. Again, in my career, I have just seen once where one of my senior residents and I was accompanying him, where we had a completely gangrenous appendix in a diabetic patient, and the base of the cecum was also gangrenous, and so we had to carry out a right hemicolectomy. So extremely uncommon. Most of the times we just do an appendectomy, but if you encounter such a situation, you have no other option but to carry out a right hemicolectomy. So these are the special scenarios which you should know. Each one has been asked as a question in the exam. What are the complications following appendectomy? So number 1, of course, there can be hemorrhage. Number 2, wound infection. This is the most common complication. Wound infection or surgical site infection is the most common complication following appendicitis, and this question has also been asked in the exam. It is written in both Bailey and the latest Sebastian as well. There can be injury to the iliohypogastric nerve. And because of this injury to the iliohypogastric nerve, it has been hypothesized that there is a higher incidence of right inguinal hernia following appendectomy because of injury to this nerve and weakness of the muscles. There can be portal pyemia. Again, because of infection, there can be portal pyemia. There can be a pelvic abscess. I've already told you pelvic abscesses can develop after 5 to 7 days, and these are going to present with pelvic diarrhea and spikes of fever. We've already discussed this problem as well in the module on postoperative causes of fever. There can be stump appendicitis. There can be stump appendicitis, and I've already told you how it presents and how do we prevent stump appendicitis. Right, so these are some of the complications following appendicectomy which you should be aware of. Now, normally whenever there is inflammation in any structure in the abdomen, I've told you that the policeman of the abdomen, what is the policeman? Correct, the greater omentum. It comes and covers that structure. So it tries to curb the chaos or curb the inflammation. So supposing the appendix is inflamed, the greater omentum will come and it will cover it up and it prevents a perforation. But there are certain situations where an appendicular perforation can occur. So appendicular perforation, what are the scenarios or the situations? What are the situations where perforation is more common? And I've already told you the most common site where the appendix gets perforated is the tip of the appendix. So the situations are in infants and young children. In infants and young children. And why does it happen in them? Because the greater omentum is not fully developed, right? The policeman is still under training. So if the policeman is still under training, it cannot do its job properly and the appendix can perforate. So a greater omentum is not fully developed. That is why perforation can occur. The other scenario is in elderly patients. In elderly patients, the policeman has retired, right? So the vessels of the greater omentum, vessels become atherosclerosed. So it has become sluggish and it cannot carry out its job properly and there can be a perforation. When there are adhesions, bowel adhesions are there. So when bowel adhesions are there, the omentum has to navigate through traffic, right? And it takes time. So the appendix can perforate in these patients as well. Immunocompromised patients. Immunocompromised patients, the omentum does not function properly, right? The omentum has gone rogue. It does not do its job properly and the appendix can perforate. And the final situation, which is also very important for the exam, is in pregnant patients. And in pregnant patients, what happens is that the appendix has to go over a speed bump. It has to go over the uterus. So that is going to take time, and in that time, the appendix can perforate. So these are the 5 situations where appendicular perforation can occur. And if appendicular perforation occurs, again, the management of these patients is going to be surgery. Management of these patients is going to be surgery, and we use a lower midline incision here. We use a lower midline incision to carry out the surgery in these patients. Now, before I talk about an appendicular lump, I want to talk about one special situation in detail, and that is appendicitis during pregnancy. And that is appendicitis during pregnancy. This is a very, very important topic. There were in fact 2 questions in the recent super specialty exam from appendicitis during pregnancy. So you should know here that this is the most common non-obstetric. This is the most common non-obstetric abdominal emergency in pregnancy. Right? So most common non-obstetric abdominal emergency during pregnancy is acute appendicitis. And almost 50% to 60% patients will come with typical features, will come with typical symptoms and signs. But 40% will not depict these typical symptoms or signs. In 40 to 50% patients, the symptoms or signs can get merged with pregnancy features. Can get merged with pregnancy features. And what are these signs and symptoms? What can happen? That pain is felt slightly higher up. Pain is felt slightly above the McBurney's. Why? because the uterus pushes the appendix upwards. So in majority of the patients, and a lot of patients, pain is felt in the right lumbar region rather than the right iliac fossa because the uterus pushes up the appendix. Then in these patients, what can happen? That there can be increased urinary frequency. There can be increased urinary frequency. And that can occur normally also in pregnancy, and that can be misinterpreted. Also, normally in pregnancy, also in the second trimester, there can be right iliac fossa pain, which can be misinterpreted for acute appendicitis. Also, what happens is that there is higher chances of perforation. There are higher chances of perforation. I've already told you, because the omentum takes time to reach that area, and there are higher chances of perforation in these patients. Okay. Now, the management of acute appendicitis during pregnancy is, of course, surgery. And surgery can again be lap or open surgery. Yes, a lap surgery is also safe in pregnant patients. It has been written in both Bailey and in Sebastian that lap appendicectomy can also be done in pregnant patients. You should know that appendicitis during pregnancy has a high rate of, there is a high rate of preterm labor. There is a high rate of preterm labor, which is 11%, and there is a high rate of fetal loss. There is a high rate of fetal loss also, which is there. So fetal loss or abortion can occur in 6% patients. So these values are from the latest Sebastian, and you should know this. Also, if there is a perforation, then these values can even be higher. The investigations during pregnancy, we usually do an ultrasound to confirm the diagnosis. If you have equivocal findings, then we can do an MRI in a pregnant patient. So these are the investigations which can be done to confirm the diagnosis. Moving on to the next very important topic, and why I say it's very important is because this is a constant short note in every university exam. And there are certain MCQs also which have been asked from this, and this is the management of an appendicular lump. Right? So why does an appendicular lump develop? So now we've discussed that if a patient has acute appendicitis, the omentum will come and cover the appendix. Now, if the patient is coming late, then this omentum is inflamed, the appendix is inflamed. So along with the omentum, the bowel also gets stuck there, right? And other structures also get stuck there. So everything gets into a jumbled up mass, and that forms an appendicular lump. Right? So when the patient has an appendicular lump, there's going to be a lump in the right iliac fossa. And in such patients, we carry out the management using the Ochsner-Sherrin regime. This is the Ochsner-Sherrin regime. And what is Ochsner-Sherrin regime? Ochsner-Sherrin regime is expectant management in appendicular lump. Expectant management or non-operative management in a patient with an appendicular lump is known as Ochsner-Sherrin regime. Now, what exactly is done in Ochsner-Sherrin regime? So in Ochsner-Sherrin regime, there are certain interventions or certain management points, and there are certain things which we need to observe. Okay. So what is the management? Like the management for all patients of acute appendicitis, we are going to make the patient NPO, nil per oral. Don't give anything by mouth, give bowel rest. Give IV antibiotics, right? Give IV antibiotics, and these antibiotics should cover both aerobic plus anaerobic bacteria. In fact, the most common bacteria which is cultured from specimens of acute appendicitis is bacteroids. So you need anaerobic bacteroids is the most common. That is why we need anaerobic cover as well in these patients. Along with this, you will give them adequate painkillers through the IV or the IM route. Bowel rest, IV antibiotics and IV fluids are also given. So this is the treatment which we offer to these patients. And what do we have to observe? It does not mean that we just dump them on the bed and forget about them. We have to closely observe the vitals of the patient. the temperature charting has to be carried out rigorously. The size of the lump, so we mark out the lump and we see on a daily basis if the lump is reducing in size or not, and the pain or the tenderness. So these are the things which we will monitor or observe in these patients. Now, when we put a patient of an appendicular lump on this expectant management, there can be two outcomes. Outcome number one, in majority of the cases, what happens is, so outcome number one is that the patient improves. In 3 to 4 days, the patient is going to improve. Fever settles down. Lump settles down. TLC, total leukocyte count, settles down. So this is another thing which we monitor. We also monitor the WBC count. Or the other scenario can be that fever increases. Fever increases. It comes with chills and rigors. There are spikes of fever with chills and rigors which are coming now. The size of the lump has gone up. Pain has gone up for this patient. Okay, so these are the two scenarios which are there. In the first scenario, if the patient improves, we are going to discharge the patient. We will discharge the patient and we will call the patient after 6 weeks. We call the patient after 6 weeks for an interval appendicectomy. Interval appendicectomy means when the inflammation has settled down, then we will carry out an appendicectomy. That is known as interval appendicectomy. And we have discussed in the module on types of wounds or types of surgeries that interval appendicectomy is a clean contaminated procedure, whereas an acute appendicectomy, when there is appendicitis, is a contaminated procedure. This is a clean contaminated procedure. So this you should know. If the patient improves, call the patient after 6 weeks and do an interval appendicectomy. But if the pain is increasing, the fever is increasing, then most likely the patient is developing an appendicular abscess, right? And this scenario was asked in the All India exam. 2 times appendicular abscess is being formed, and here we abandon the conservative regime. We abandon the conservative regime. And after abandoning the conservative regime, we carry out extraperitoneal drainage. So this is very important. We carry out extraperitoneal drainage of the abscess. We carry out extraperitoneal drainage of the abscess. Okay. So that is the management of an appendicular lump and Ochsner-Sharon regime, which is a very, very important short note for your college exams. And that takes care of the management of acute appendicitis in general. I have covered up various aspects. This is a very, very important topic for your exam. Now moving on to the other thing in appendix, and that is appendicular tumors. Now appendicular tumors, the most common appendicular tumor is carcinoid tumor. I've already covered carcinoid tumors in the module on adrenal and neuroendocrine tumors. So for more details, you can refer to that module. But I'll quickly again summarize appendicular carcinoids. So the new name for appendicular carcinoids is known as ANEN. What is ANEN? This is appendiceal. This is appendiceal neuroendocrine tumors. Neuroendocrine neoplasms. Right, so that is the new name for appendicular carcinoids. You know that appendix is the most common site for carcinoid tumors overall. Now, appendiceal neuroendocrine neoplasms, they can be divided into, according to classification, they can be divided into G1, G2, G3. G1 are well-differentiated neoplasms. G1 are well-differentiated neoplasms. G2 are moderately well-differentiated, moderately differentiated. G3 are poorly differentiated neoplasms, right? Another category is manic. This full form also you should know. All these are written in the latest Sebiston. These are all updates from the latest Sebiston. This is mixed appendiceal. This is mixed appendiceal neuroendocrine neuroendocrine neoplasm, neuroendocrine tumor. So this is manic tumors. Okay. Now, when we talk about appendicular neoplasms or appendicular neuroendocrine neoplasms, size is the most important determining factor. This is the most important determining factor which tells us about the malignant potential, and it also tells us how these patients should be managed. Okay. So if the size is less than 1 centimeter, simple appendicectomy is enough. If the size is less than 1 centimeter, simple appendicectomy is more than enough. If the size is more than 2 centimeters, we have to carry out a right hemicolectomy. This I've already told you in that module. So this is an update from the size. Earlier it was less than 2 centimeters. We just do an appendicectomy. More than 2 centimeters, we carry out a right hemicolectomy. But now in Sebastian, they further segregated. Less than 1, we are definitely doing just an appendicectomy. More than 2, we will do right hemicolectomy. 1 to 2 centimeter, it is based on the clinical judgment. And also the location of the lesion. If it is located close to the base, then we go for right hemicolectomy. If it is situated at the tip of the appendix, we go with simple appendicectomy. Now, one thing which you should remember, that when we do the simple appendicectomy for endocrine neoplasms, for neuroendocrine neoplasms, it should be with removal of mesoappendix. So you excise the mesoappendix as well, so that the chances of recurrence are reduced. So this is the latest management as per the latest Sebastian for appendicular neuroendocrine neoplasms. Now, another thing which you should know about another tumor is appendiceal mucinous neoplasms. AMN. Right? This is another terminology, appendiceal mucinous neoplasms. So you should know that the most common malignant tumor of the appendix is mucinous adenocarcinoma. So the 3 new terminologies in appendicular mucinous neoplasms are low-grade AMN. Low-grade AMN has replaced term appendicular mucocele. So earlier the term of appendicular mucocele has been now replaced by low-grade appendicular mucinous neoplasms. The other 2 are DPAM, that is disseminated peritoneal adenomyosis. This is DPAM. And the third one is peritoneal mucinous carcinomatosis, that is PMCA. Now between the last 2, DPAM, that is disseminated peritoneal adenomyosis, this is just locally invasive. And this is slow growing. Whereas peritoneal mucinous carcinomatosis is more aggressive. And this can also show distant metastasis. So these are the 3 new terms which have been mentioned in the latest Sebastian, and you should know about them. Now, let me just tell you about these mucinous tumors and also about pseudomyxoma peritoni. I just want to tell you the basic management, because there is one new technique which is being done, which has been asked in the exam, especially in the SS exam, but it has also been asked in the PG exam. So pseudomyxoma peritoni or mucinous tumors can either be primary peritoneal tumors. That means they arise from the peritoneum itself. or they can be secondary to appendicular mucinous neoplasms, which I just told you, or they can be secondary to ovarian mucinous neoplasms, or they can be secondary to ovarian mucinous neoplasms. Right? Now, in these tumors, what is done, once you make the diagnosis of these tumors, what is the surgery which is carried out? So, the surgery which is done in these patients is called cytoreductive surgery. It's called cytoreductive surgery, or CRS. Now, cytoreductive surgery basically means debulking surgery. We are trying to remove as much as we can. This is debulking surgery, right? This is not R0 resection. R0 resection is not possible. R0 resection is not possible in most of the cases. Remember, we've already discussed what do we mean by R0, R1 and R2. I'll quickly recapitulate because this has also been asked quite frequently. R0 resection is when there is microscopic freedom from disease. R0 is when there is microscopic freedom from disease. That means I've entirely removed the disease. R1 resection is when microscopic disease is still present after surgery, and R2 disease is when gross disease is present after surgery, right? So these are the three types of resections which are done. Usually we do an R0, but in certain situations like in these mucinous neoplasms or pseudomyxoma peritoni, where there is jelly-like material all over the abdomen, all over the peritoneal cavity, there R0 resections are usually not possible. So in this debulking surgery, what is carried out? What all do we remove? We carry out an appendicectomy. Or a right hemicolectomy. If appendix is primary. If appendix is the primary. Then we do a TLH plus BSO. If it's a female patient, a total abdominal hysterectomy is done. A total abdominal hysterectomy plus bilateral salpingo-oophorectomy is carried out. In addition to this, we carry out omentectomy. We remove the omentum. We carry out para-aortic and iliac. Para-aortic plus iliac lymph node clearance is done. Plus, we strip off the peritoneal nodules. Any growth on the peritoneum is also stripped off. So all this is removed in this cytoreductive or debulking surgery. So we are trying to remove as much as we can when we do this surgery. Now, the thing which I want you to know is that once this surgery is completed, that is not the end of the treatment. Then we just do temporary closure of the abdomen. And we do HIPEC. What is HIPEC? HIPEC is hypothermic intraperitoneal chemotherapy. So what we are doing is we put in tubes inside, and we are going to put in heated chemo agent. So this is at 40 to 41 degrees centigrade heated chemo agent. Why are we heating it up? Because it increases the efficacy, right? It acts in a better manner. And why are we giving it locally? So that it can clear the local disease, it can control the local disease. Whatever we've not been able to surgically remove, that it can take care of. And what are the agents which can be given? The agents usually used are mitomycin C, paclitaxel. Mitomycin C are the agents which are used. So this solution is kept inside the peritoneal cavity for an hour or so. Then we drain out the solution and then we close the abdominal cavity. So that is the management of these patients. We do a cytoreductive surgery followed by HIPEC. I want you to know the term of HIPEC. I want you to know the temperature and the agents which are used. Once this is done, then the patient is going to get adjuvant chemotherapy. That means once the patient is recovered from the surgery, then they get normal chemotherapy, which is Pacli and Carbo. So that is paclitaxel and carboplatin. That is the chemotherapy which is given in these patients, and that is the management of pseudomyxoma peritoni and high-grade appendicular mucinous neoplasms. So that brings us to the end of this module, and as we've been doing in all modules, for final year students, I told you this module is very, very important. So you get a short note on appendicitis. You get a short note on Oshner-Sharon regime, which is very, very important for the exam. Oshner-Sharon regime. Right, in the Viva, appendicectomy steps are very important, so please go through the video which I have shown you. Appendicectomy video is extremely important for the exam as well. Now before we end, let's quickly do some MCQs. So a surgeon performs an appendicectomy with a grid iron incision. He later converts it into a Rutherford-Morris incision. Which of the following muscles are cut? So I told you external oblique, internal oblique, transversus are cut. Rectus abdominis is not cut. Rectus abdominis is more medially, so that is not cut. So it is 1, 2, 3. This was asked in the INI-CET exam. All of the following are part of the Alvarado score except left shift of neutrophils, fever, anorexia. Rovsing sign, none of the signs, SOA sign, Rovsing sign are not part of the Alvarado or the Mantrel's scoring system. Which of the following statements are not true regarding appendicular surgery? So we are doing true and false. Gridiron is a muscle splitting incision. This is true. Lanz is used for interval appendicectomy. This is true. If the appendix is non-inflamed during appendicectomy, we should carry out an appendicectomy and close the incision. This is false. I've told you, what do we do? Correct. Search the last 2 feet of ileum for an inflamed Meckel's. If there's no inflamed Meckel's, then you can remove it. If the base of the appendix is inflamed, we should bury the base. This is true. If the base is gangrenous along with the cecal base, we should do a right hemicolectomy. This is also true. These scenarios are extremely important from the point of view of the exam. So a pathologist receives a specimen of a patient and is surprised to find a 1.5 centimeter carcinoid tumor situated at the base. Right? I told you 1 to 2 centimeters. If it is close to the base, what do? We will do a right hemicolectomy. Correct. So these were the questions regarding appendix, and that brings us to the end of this module. Thank you.